There's no background.
Hi, good afternoon, everybody. We've got another Friday live session on LinkedIn. These sessions, for anybody that's not seen another one previously, are all about being proactive and showcasing things that are actually getting done that can make a difference in the public services and the public sector. It's all about being positive. Yes, we discuss issues and problems, but it's more about that proactive, get stuff done. So I'm really enjoying every one of these Fridays, and today I'm really looking forward to this UKDHC session. I think, like many of you, I'm just going to sit back and do a lot of learning today. Hopefully we'll contribute as well. To the people on LinkedIn, if you can put your comments into the comments within the chat sort of comment section in LinkedIn, we can pick them up as a panel as we go through, and we'll weave those comments and questions into what we do. We'll do a quick round robin in terms of who everybody is, and then we'll get into the presentations, and each presentation will be interspersed with us discussing the issues and the comments and our perspectives. So it's all really relaxed. Again, I encourage people on LinkedIn to comment and join in as well. So I'll start off just with a quick introduction. My name's Anthony Lawton. I'm the founder of Fit to Care and Insight Genie, and I'm on a mission to really help drive performance and outcomes in public services, and to really improve the health and well-being of staff, because I think it's really important. So I'll hand over next to Angus for his quick intro.
I'm Angus Wallace. I am the Executive Director of UK Digital Health and Care, and I'm hosting this with Anthony today. I'm delighted to talk to you about the UK Digital Health and Care plans.
Excellent. So Jane next.
Yes, hello everybody. I'm the course leader for the MSc in Health Informatics at the University of Central Lancashire. I'm also a senior lecturer in Health Informatics and Evidence-Based Practice, and I'm on the Education Committee for the UKDHC.
Fantastic. We've got some good academic panellists today. And over to you, David.
Yep, my name's David Wright. I'm a former Chief Exec of the Royal College of GPs in Australia. I'm also lecturing in an MSc in Healthcare Management, and I've been an advisor in the Middle East to 2 governments on quality improvement in healthcare, and I'm now residing in the UK and getting behind UKDHC.
Brilliant. Right, I feel like I'm not worthy with this set of panel members today. Do you need to go into your slides now, Angus?
Yes, please. That would be perfect.
Okay, and maybe put us down the side.
That's lovely. Well, UK Digital Health and Care started in April 2024, and one of its main aspirations is to support training for professional frontline health and care staff in the UK. We are very aware that at the moment, a lot of new apps, electronic patient records, and digital help is being provided in hospital and in social care. But we believe there's quite a gap between what staff are able to do and what can be achieved with the equipment that's been installed. So our plan over the next year is to help everyone to become better at using digital equipment, better at becoming more digitally competent, and providing better and more efficient care as a consequence. We're not asking people to work harder, we're just asking them to use the facilities that are now being provided, use them well, and in that way, not only will you save time, you'll actually have an easier life. Next slide.
What an amazing topic this is.
So what is the UKDHC real deal? Well, that is remote evaluation and lessons. So we're going to provide remote evaluation and lessons. And the deal is We are going to provide digital expertise assisted learning. And everybody will be able to access that on the web. And our aspiration is that we help you all get better at doing what you are doing in hospitals and in care homes. Next.
Well, I've got loads of questions already. I'll let you carry on now.
Online skills assessment is going to be carried out for all professional health and care staff in their digital skills, and Jane is going to talk about that. We are going to provide a signed certificate identifying what digital skills you have and what your deficiencies are. You can print off that certificate from the web, and you can either bin it if you don't like what we say, or you can give it to your employer and ask them for help with improving your digital skills. We are also, during the next year, going to be signposting you to courses available to cover your deficiencies. You will have the option of joining our UKDHC Real Deal free teaching online with mini modules aimed at professional NHS and healthcare staff. And I have been working with Jane with the University of Central Lancashire and 8 other UK universities who are in the process of developing mini modules so that we aim to get one module online each month over the next year. The first module, mini module from the University of Central Lancashire, will be up in March this year, and then we'll have new modules monthly from April 2025 onwards, and with every module you will earn a certificate if you complete it satisfactorily. So that's our plans, and Jane is going to tell you what she has been working at to make that all work. Over to you, Jane. Next slide.
Thank you, Angus. So obviously this is me, course leader and senior lecturer. If you move to the next slide, please, Anthony. So our credentials for undertaking this piece of work is our MSc in Health Informatics has been entirely distance learning for 25 years. There are no live sessions, and there's lots of online support if you need it. So tutors are available, obviously, but it's been purely distance learning. I was trying to add up the number of students we've had through in the last 25 years, and I lost track somewhere around 2,300. So we've taken a lot of students to our MSc using this method. All we ask is that our students work in health or social care somewhere, because all of those assessments are workplace based, so everything revolves around them and what they do. Next slide, please. So the first thing we're setting up, and this is almost ready, and I will come to that in just a moment. So we have a digital assessment tool. This will be available on the UKDHC website, and it goes with the digital literacy competencies with the digital literacy framework. So you can see there are 6 sections to that digital literacy. There are a number of questions which you can answer across each of those sections, and each section then will give you your own digital summary of where you are and what you could do next. So the idea is you do a section, you get your report, you look at where you are, where you need to improve. We can then signpost you to other resources which are available, most of which will be free. We're busy making sure all of those courses are validated. And then you can also go off to your supervisor and go, right, I need to improve in these areas. And hopefully they can send you off, perhaps with some funding. So that will be available on the website very, very shortly. We had a small hiccup because when we were setting it up, for some reason, we use it with staff, we use it with students, but when we're making this for specifically health and social care staff, one bit of it didn't work. No idea why. So that's had to be fixed. That is, we think, fixed now. So we're just going through final testing. So that's the digital assessment tool. You can go in, you can do it as often as you like. You perhaps want, if you're having an appraisal, you could go and you could redo it and see how you've improved and where you can go next. So that's the digital assessment tool. That's going to be the first port of call for everybody. Next slide, please. And then moving forward, there are going to be all these different module materials, taking what we've learned over the last 25 years. So it's very, very important that every piece of learning that we're giving to everybody, pre-start information with very, very clear expectations. If we don't do that, then people will start a course, isn't it easy? You click on a button, start that course, no idea what I'm doing. So very, very clear expectations. And then familiarity. We know that students like a consistency of approach. They like familiarity with material design because they know where they're going. I did a piece of training myself earlier on last year, and the woman who was doing the training said, click on this button. And I have a visual impairment, as some of you know, but I was looking at the screen going, where is the button? And it was really salutary for me to realise that where we think things are perfectly clear and obvious, and they're not necessarily to the person looking at it. So when we're looking at all these different modules, all these different bite-sized chunks of learning that we're going to be doing, we need to be as consistent as possible. So we're going to be talking about how we're going to do that. So these module materials, some of them are going to be absolutely modular. So people can work through a particular subject. The first subject is going to be what everybody needs to know about health informatics, because obviously that's my thing. And they will work through it. It will take about 2 hours, and then there'll be a learning check and a certificate at the end to say that they've completed it. Now, all of these materials, we're talking about podcasts, webinars, YouTube videos, activities, quizzes, and those learning checks. We can use those in different ways. Sometimes it's just going to be a podcast, and I'm already talking to a number of people where it's going to be really, really interesting to talk about different aspects of digitalization, digital transformation within healthcare. And then what's also important, where it's a longer piece, is that ability to stop-start. So that is being built in as well. They might do an hour of a 2-hour learning program where that's all I can do for today. So they need to be able to start and then go back to the same place. So that's the other thing that's going to be really important. And I think that is, so what makes it work? Yes. So bite-sized chunks with options for everybody. So we want a collection of learning materials that everybody can buy into. So it's not just, it's not just the clinician. It's everybody who needs to upskill their competencies. And we really are looking at aiming to increase both confidence and capability. Those are the two main things. If you increase people's confidence in being happy to go out and actually take a part, to actually learn new things, their competencies are going to improve. The other thing that makes it work, they can see that it's related to their work role. So they can take away what they've learned and apply it straight away. It's support. One of the things, it's going to be quite difficult to have a module or a piece of learning material sitting on an external website and provide support, but it's going to be essential that each piece of learning material has somebody that can be contacted, because if something doesn't work, we need to look at it and we need to be able to support that student straight away. I think that certification is absolutely imperative. People need their CPD points. They need to be able to go and prove that they have actually undertaken some sort of professional development. And then that signposting to further verified learning, absolutely essential. So those are the 5 things which are absolutely key to making this work. And these are what are going to be what are absolutely set in stone within all our materials.
Right.
So I say don't just take it from me. You know, distance learning can be hugely beneficial to everybody. This is a student who they didn't complete the MSc, so they are talking about their MSc experience. But I think what they say is applies to just about everybody. You know, everybody's working. Most people are not local to a university. They don't have that much time, so they need to be able to work at their own convenience, and then being able to apply that learning day to day in their career. Those are the things that make the difference, and that was a quote say quite recently. So that's where we're going. That's what our aims are. We are well on with all of that, and certainly by the 1st of March, the digital assessment tool will be up before then, but the 1st of March will be the first module that will be available as well. Always happy to talk about digital learning, about health informatics. So anybody who's listening now, please do feel free to contact me if you wish to do so.
Fantastic. Just before we get on to David's slide, so we'll just have a little breakout. I know Jane's got to go in 13 minutes. Shall I just start with a couple of questions that have hit me? First of all, I feel like I've really made a mess of promoting this because I wasn't really aware of how much value was involved. I think big learning curve for these future sessions is we need to get together and really appreciate what the value is so that we can promote it better, because I just think this is an amazing resource. I'll come on to a minute why it's so pertinent to me and why it's made me go, wow. But a couple of boring questions first. So it's free by the sounds of things, or the majority of it. You might signpost off to some areas that might not be, but fundamentally what you guys are doing is free.
Yeah.
Just a practical sort of admin-y type question from me. Are you guys got funding for a while then? People are confident that they can go into it and it'll be there in the longer term?
We have a number of sponsors, commercial companies who like what we are doing. And you can see what sponsors we have on our website. And their financial contribution is helping us to do this. But a lot is being done out of goodwill. We have developed a good collaboration between all the universities in the UK. Excuse me. All the universities in the UK who are running informatics qualifications. And we're working with, you talk about Judy, Jane. She's very keen to be involved. She's University of Cardiff?
Yes, Cardiff.
Well, just tell us a little bit about her, because she's coming in and joining us in this venture, isn't she?
She's very, very keen to join our education committee.
Yeah.
Very, very keen to provide, like the University of Central Lancashire has, some sort of module content. So we're talking about what that might be according to her particular interest and what we think will be useful moving forward. It's especially in the early days. You know, one of the things we can do is we're starting off sort of quite broad brushstrokes, if you like, but as we move forward, we can get more and more and more specialist input.
I've had contacts, Anthony, with a number of universities in London, the University of Edinburgh, University of Glasgow, Strathclyde University. We really do have the contacts that are going to make this work. You made the point, it sounds like an expensive exercise. It is a bit expensive, and we are hoping that we get other companies coming and supporting and sponsoring us to do this, because we really believe it's important for the NHS and for social care. And it is amazing when these companies hear what we are doing, they actually get quite excited. And I'm not allowed to mention any names at the moment, but we have a couple of big ones who are waiting to jump in. David is in charge of that, and he might mention it during his talk.
That was my reaction as you started talking. I just felt, my God, this is a gap that needs to be filled. And I think the fact that it's got so much academic rigor behind it will give the confidence that this is robust material. It's well thought through. It's brilliant stuff. So all that together is really impressive. can I just ask another question or two whilst we've still got Jane? You know, Angus, that I'm writing a book at the moment, The AI Strategic Edge, and I've asked you kindly to do the foreword for me, given your background in health as well. And I'm doing quite a bit of research at the moment, and what I'm finding, that again, completely links to this in my mind. It's a bit of a hypothesis of mine, but I think at the moment there's a massive gap for AI education. So I'm in the book research, I'm finding lots of people in the public sector saying things like, and this will be in the book, but things like AI is rubbish, it's just repetitive, it's making stuff up, loads of this stuff, which is really interesting for me in terms of the book, and I'll address that in the book, obviously. But it feels like there's a massive opportunity for your work in this area as well. And I also think it's things like sort of garbage in, garbage out. Copilot, my hypothesis, isn't great at the moment. It's not producing great stuff. Yeah. If you double that with people not using it properly, that's where you get these responses like it's rubbish and it's, you know. So education's massive, I think, in this area.
Yeah, I agree entirely. I mean, we have an MSc in digital health as well at UCLan, and we have a module on that all about AI. And something that we might take out. I might use some of that and do some modular work for the UKDHC.
AI is going to contribute a lot to health, but you have to accept that it's not perfect. And even when AI within the large language modules and various other parts of AI, although it's good, it does have what are called hallucinations, and it does start telling you lies. So you've got to be aware of what goes on.
Yeah,
absolutely. Education's key, but you can deal if you use it properly and set it up properly. You can get away with a lot of that risk, but that's for the book. I won't hijack this one.
One of the strands through the health informatics program is teaching students to use AI constructively, understanding what it is, understanding what the shortcomings are, and how they can make use of it in a constructive way. So that is a strand that runs across both of our programs.
Fantastic, brilliant. So is now a good time to bring up David's slides?
Yes, please.
Great stuff.
Anthony?
Yeah?
Can I control my slides?
Yeah, actually, I can let you share screen and take this down.
Okay, I'll share my screen and then...
While David's sharing his screen, we've had a question about the general public. We are an all-inclusive organization, and we are very keen to involve the general public. Patients need to become better at using the NHS app. They need to become better at using apps in general for improving their health. And we're very happy for patients, for the general public, to come and do some of the studying that is going to be done by the health and social care professionals. There is no barrier. They can come and get a certificate as well, but it will be a certificate for the general public person.
Brilliant.
David.
Thanks, Angus. Anthony, can you see that?
I can't see yet. It's not popped up with a asking to share.
Okay. Can you see my screen?
No, we haven't had
Hang
that.
on.
There we go. Show on stream. There we go.
Yeah.
Okay, thank you. I'm going to take a little different tact and then come right down to the key topic, come back to it. But I just want to highlight some of the issues and bring my thoughts to the table, because I've tried to share these thoughts with, and I've worked it out on a bit of paper this morning, that I've now shared this with about 6 ministers of health, 2 of which became prime ministers, and shared it with 4 different countries' ministers of health. And so many of them don't get it when it comes to resource allocation. And listening to what's happening in the NHS, because I've been away from the NHS now for 40 years, having worked in Australia and the Middle East, it's now hitting me quite strictly between the eyes, and that's what's got me behind UKDHC, in that the only way to solve a lot of these problems is through some of the programs that you will find that UKDHC is developing. If you take, I want you to take a really big picture look for those listening online, and get in a helicopter and look down on the system. Volume and complexity. If we divide it into 3 simple sections, and I'm taking a very simplistic view on this, and we'll come back to the pressure areas, and we'll come back to how education can assist in lifting the competencies and skill sets of those that work in the health system, not just the NHS, but also private care. That's the volume.
David, can I just interject and say people will see this much better on full screen if they click the full screen button. Okay, thanks.
Thank you. Okay, I'm seeing it on full screen, so yeah, that's the volume. You get a headache, you go to the pharmacist, you get some ibuprofen or whatever you want. You look after yourself. Primary care, secondary care, tertiary care. The complexity as you head towards tertiary care, secondary care. The cost goes way high as soon as you get into the complexity. The 40 hospitals that were planned to be built, the amount of money that goes into secondary and tertiary care. I'm not saying that it's not worthwhile. I'm just saying that that is the high complex area and also the high cost area. However, this integration between the two is always problematic, and it doesn't matter where I've worked over the last 40 years. It was the same in the Middle East, it's the same in Australia. Ambulance ramping, discharge planning, not enough beds to discharge to in social care, etc., etc. So those 2 lines, and how to move those 2 lines to the right, that's been something that it's been challenging me for a long time now. But that curve there, the volume curve, is going up, obviously with aged care and so on, and complexity and comorbidities, etc. These 2 critical, these points here are the ones that hit the news, the front page of the papers, the beds in corridors, the primary carers, you can't get an appointment, you can't discharge properly, the admission planning between primary and secondary care, the communication between hospice care, etc. Those are the real critical points that actually hit the news. If there is no news on Monday morning, you will find there's something to do with healthcare on the front page. That's what usually happens with journalists. If they've got nothing else to write about, they'll write about healthcare. Those are the key pressure points. How to move those 2 to the right, those 2 lines. That's healthcare. We're looking down on this from our helicopters. Just look at the key numbers that are in there. I'm just looking at the UK, 68 million population. We should all be looking after ourselves to some degree, but we not all of us can, etc. I found it hard, very difficult yesterday, using the NHS login system to make an appointment with my primary care. I found it difficult because exactly what Jane said about it's finding the right buttons on the page, on the screen to how to log into the appointment section. It was difficult. There are 1.3 million staff that work in the NHS. There's also 1.5 million that work in adult social care. So there's 2.8 million staff that work in healthcare just in those key sectors. That if we can raise their level of skills and competencies of using IT and IM just a fraction, we're going to make a difference. if we can raise the competency of skills of people that design systems to assist with discharge planning, with regards handover within hospitals, the A&E, the triaging of patients, and of course, stopping patients clogging up primary care because of greater social care. And I'm going to highlight one little issue, and this was raised to me on a teleconference a few weeks ago when a cardiologist said, wouldn't it be great if every child, everybody knew the simple key parameters of heart rate, cholesterol, blood pressure as part of their education, just a simple understanding. And then I thought to myself, oh, well, how do I understand my heart rate? How do I understand my some of my KPIs for my own health? And I looked at self-care. The average spend per person in the UK, this is the 68 million, the average spend on health and beauty is £4,600 per annum. And then I looked at how much is spent on smartwatches, which tells you your heart rate, your sleep patterns, and it's £15 is spent on smartwatches per head of population. I just threw that in as a side issue because it came to me as a bit of a thought process with regard to self-care. How can we move this line to the right? How can we look at these people that work in the NHS in social care and offer them opportunities of raising their skill sets, of using IT and IM to make their positions more effective, more efficient, and understand the interaction with the rest of the healthcare system? Until we do that, status quo will prevail. How do we move these lines? And I've just thrown on the page some ideas, but the underlying issue is all to do with education. I'm a great believer in I'm an ex-teacher from my original training, and it's see one, do one, teach one. And that's what underlines the apprenticeship model. In fact, if you want to become a surgeon, like Angus, if you want to become a surgeon, you see one, you do one, you teach one. And it's just a continuous mentoring process with those that are coming through. And if we can educate the youngsters coming through who are going to be working in healthcare, who will know more about IT and IM than we can ever dream of, that will be a positive move. Self-care is about education, education, education. It's about remote patient monitoring, preventative HAPs, and self-management. Moving these lines. Primary care is upskilling and pay for complexity. I fought for 8 years to get GPs paid more in Australia for dealing with more complex issues rather than click-clack medicine. I argued that you could pay a GP a lot more for doing more complex issues and stop people going to the A&E departments and clogging up the A&E departments. The use of effective IT and IM and data sharing, of course, and lots of this is occurring already, but there's still lots of negotiations, I'm sure, that's going on. But I know that Streeting and the team at the NHS are calling for submissions and ideas to move these lines, and I encourage everybody to be part of that. Community care, integrated IM communications, and leverage technology. You mentioned AI just now. This morning I was on a teleconference with a group of academics who were dealing with AI and students, obviously to do with plagiarism, but also one of them came up with a really terrific concept that we've got cognitive offloads. In other words, you can look up things on ChatGPT, you can look up Perplexity, but we've still got to encourage cognitive thinking. And that's why I'm a great believer in MDT teams with regards the use of other people's skills and inputs into solving problems for medicine. This is something that I don't think we do enough of. Listen to the workforce for ideas for change and improvement. Those are the ones that know where the problems are, the vacuums, the issues, and how to solve them. It's not top down, it's bottom up. And if we can focus on the conditions for staff that are working in healthcare and improve their conditions, improve the standard and knowledge base of people working in healthcare, even the better. The key outcomes will be better care for patients and better outcomes.
Brilliant. Excellent. Really, really good stuff. I don't want to hijack this, David, but we must catch up, just the two of us, after this event at some point when you've got a slot in your diary, because the workforce bottom-up piece is my driving force at the moment. So it'd be great to catch up with you and pick your insights on that.
Well, the last thing I mentioned, it's education. And if you can educate the population, you can educate those that are working in healthcare and get them to collaborate. We're all going to be better. And UKDHC, that's why I'm passionate about helping them in their journey. Yeah,
it sounds a fantastic venture. Jane just had to leave a really urgent appointment at past, so she's said that, but by all means, everybody can get in touch with her and engage with her directly. Any questions that come up from this. We've just had a couple of points in the chat around, is this recording going to be available afterwards? Yes. If you go to my profile, Anthony Lawton, you will see this on the same page that you registered. It's in the events section in my profile, and you'll find it. It'll be there after this session. All of the ones that we do are recorded, so they're always there, which is good. Really good system from LinkedIn. So shall we hand over to you next then, Angus, just to wash up on David's section?
We're a totally inclusive organisation. We are committed to helping and supporting both the NHS and social care. We believe very strongly that we can make a difference, and it is our aspiration that we can make people's lives easier. We don't want to make them more difficult. We're trying to make them easier. We're trying to make them more efficient. We're supporting them so that they feel they're doing a better job in the workplace. And I think that's really important in today's society. I think that there has been a lot of criticism of staff working in the NHS and in social care when they have been overwhelmed by the various things that have happened to them. And I am delighted that we are going down this route to give them the support that they need to do a better job. I know David has very strong views about the social care side. Do you want to just voice these a little bit, David?
Yeah, it's when one thinks about healthcare, obviously the focus ends up on hospitals, but in reality, we spend about 5% or even less of our time in a hospital. The rest of the time is 95% of healthcare is provided in the community, and it's joining up the dots within the community to make it seamless with regards you want access to information, whether it's in Australia it's my patient record, limited access, but it's getting people to sign in, populate it, and so on, which is many countries are struggling with that issue. But as I found out this morning on this teleconference with some of these university characters in Europe, they were talking about the problems associated with getting access to information out of their hospitals for their specialists working outside of the hospitals even. Yeah. And this transfer of information, yes, obviously it's highly confidential, but we've got to focus on the patient. What's in the best interest of the patient? If they opt in and allow it, let's get behind them. Let's make it easier for them.
I was
Absolutely.
speaking to a patient earlier today, a very nice lady who trained with me at medical school and now has complete kidney failure and is on dialysis. And she was telling me that one of the things that she has found amazing has been the monitoring of her blood tests during dialysis, because not only do the doctors get the results almost immediately, but she gets them. She's in Scotland and she gets them on an app provided by Patients Know Best. So the system can work, but at the moment it's a bit haphazard. It is getting better, and everybody is trying very hard to make it better. And we are going to be frustrated over the next couple of years while that happens. But we are improving, and we'd love to help that improvement accelerate.
Brilliant.
I'll share a little story, Anthony, before we finish.
Yeah, I've got a few more questions for you as well, David.
Okay, 1973, I was a student in London, going through my first education degree, and I found a vandalized phone. And I was driving an old Ford Anglia at the time as a student, with a ripped rugby jersey and living off a couple of pounds a week as a student. And I found this vandalized phone, and I was driving on the main road coming into London. That I'm just trying to the great whatever it is by Gillette Corner, and I pulled up to a traffic light, and a Rolls Royce pulled up beside me, and I lifted up this vandalized phone with the black cord underneath it. This is 1973, and I could see that the couple in the car in this Rolls Royce looked across at me. He had a cravat, she had a big fur collar, and their mouths dropped. And I wound the window down. Their window came down, and I said, "It's for you." And I think they were called either Nokia or but the distance we have come. You can order something on Amazon or whatever, and you get a message back to say it's been dispatched.
I know, it's
you can
insane.
transfer funds across the world, and you get a notification saying we've sent it. It's in your email box. Notification. We need to be able to do that between healthcare professionals. We need to be doing that with patients to cut down on anxiety, errors, etc., etc.
I've just done a post on that very point around data and data sharing, David. I think it was yesterday.
Yeah.
So your slide made me think about a GP post this week where he was talking about we will meticulously MOT our cars every year without fail. And yet from a healthcare perspective, we can go decades without actually thinking about our own health.
Yes.
And it's a bit like your slide with the spend on beauty compared to what we actually spend on proper health stuff.
Yep.
It's crazy.
Anthony, I am going to butt in here. The reason you're not aware of it is that you haven't reached some of the older ages some of us have. And we are getting automated messages asking us to go and have our eye tests and have our blood tests and have all sorts of things. So it is happening. It's just the younger generation haven't experienced it yet because you guys are all too fit.
I'd like to put myself in the younger generation. I think I'm beyond that now, unfortunately. But no, it's really, really interesting. The final question, I'm doing some work with some experts in all sorts of fields these days. I've got some absolutely amazing content. How can these guys contact you to say, we'd love this content to be on your platform? Obviously, you'd have to go through it rigorously and check it's robust and brilliant stuff. But is that open to people that feel like they've got something to share and want to?
There are two ways of doing it. We are not an advertising organization, and we do not charge people to advertise on our platforms. We do, however, run weekly webinars If the topic is of direct relevance to what we've been talking about today, we would welcome people to come and speak in our webinars. We have a system where we have a 1-hour webinar on a Wednesday night from 6 p.m. to 7 p.m. The one next week is going to be talking about the next 2 years NHS plan and how UKDHC is going to contribute to that. The one after that is going to talk about apps and how apps are being used by patients. So if people have that sort of information they want to share, we are happy to do it. We cannot endorse companies and organizations. And if they come on our webinar, we will ask them some awkward questions as well. Yeah. We try to be very balanced.
Yeah, fantastic.
And Anthony, this is one of the things that attract us, agnostic.
Yeah.
No political affiliations.
Yeah.
It's a membership-based organizations. People power will improve healthcare. Nobody else is going to do it for us.
Yeah, I agree, 100%. And it's a good thing that Elon Musk hasn't knocked on your door with 100 million pounds so far.
You won't let him be a member.
We wouldn't accept it. I mean, if he wants to come and be a member, he can come and pay the annual membership fee. But we don't deal with people like that.
Okay, brilliant. Well, that's really good to know. And I've learned that we need to do a much better job of promoting what you guys are doing. That's for sure. Really brilliant gap in the market that you're filling.
I think, Anthony, if you can make sure this goes up as a recording, the whole of the presentation, that would be great.
Absolutely.
And we can either point to it from our website or perhaps copy it and put it down in ours. We'll decide that after. Okay.
Yeah, what I'll do is it'll be on the LinkedIn area, but I'll also upload it onto my my YouTube channel. And
we could point to it there. Yeah.
I'll do a summary post on LinkedIn as well, and just pull out the highlights, because it's a brilliant mission that you're on. Really brilliant. Excellent. So if anybody in the audience has a question for us just before we go, let us know. Just type it in. I've really enjoyed that session. I really, as I said right at the beginning, I like to just absorb what other people are doing and learn from it, and it's been awesome. So, and I'll post people to you guys as well as I come across them.
I am very to receive any comments, any support, any criticism. We always know that we can do better. But people can use my email address, angus.wallace@ukdhc.org.
Yes, and I was just thinking maybe if the three of you could put your contact details or LinkedIn details in the posts, in the comments area of this, in my area of event. People have got it there then, and they can always come back to it and find you that way, especially Jane's, because Jane had to leave a bit earlier. But yeah, we'll sort that out. I will make sure we get it published and uploaded to places. And maybe in March, when things are all up and running and launched, we could maybe do something else. Or maybe, I think April's all booked up, but maybe April or later in the year we could revisit and see how you guys are getting on.
That'd be lovely. Thank you.
Fantastic. Thanks everybody, and we'll see you next Friday. Thanks a lot.
Thanks for your time.